And I'd like to open the panel for questions. Please say to who you direct your question. Please.
Hi, my name is Rafael Gordetsky. I'm from Hadassah University Medical Center. And I want to comment about Dr. Feuerstein's lecture. Of course, about the future medicine, synthetic medicine, stem cells, and so forth. I think we have stem cells already in two decades, 3 decades. People are working on stem cells. We have all kinds of stem cells. I don't want to bore everybody by describing them. Still, not even one tissue engineer is really, a tissue is really functioning. So the question, is it really a hope or a hype? That's what I myself, I have to admit, I work with stem cells. But there are studies that show that stem cells do have some effect. If we inject them, eventually people feel better, different diseases. I don't want to get into details. But the effects is only as a bystander effect and not really by engineering the tissues. Then comes the question, should they be stem cells? Because stem cells means that they can differentiate to make all the tissues, and they just secrete something which is like a pharmacy that you inject into the patients. So I just want to put it in the focus that some of our expectations that we take it for granted, yes, in 2, 3, 5, 10 years we'll have new pancreas. Well, it's not straightforward, and so far it hasn't justified itself, and that's what I referred to Professor Sorek's remarks here. Thank you.
So that's not really a question, I guess it's a statement. Okay, so, but the good thing about the question or the statement is you mentioned the word hope, right? So the century just started. I think the fundamental technology is available in prototypic way, and if the thought is correct that you can engineer and you can use your own body to plan ahead years to supplement decaying cell or organ and then replace what you need, all the science that will allow that to happen is in its fundamental component available. The century would have to put them together and learn what is working and what is not. Like everything else, it's a reiterative process. It's a market-driven process. It depends on the successes. But everything is possible in that direction. There is no reason why you will not use your own cells that you have been born with in order to produce a new organ that you don't have anymore, and living without a pancreas, for example, is not convenient. Well, that type of thing.
Question is for Dr. Agus. Are we likely to see a revolution in our understanding and treatment of psychiatric disorders such as ADD and ADHD and
It's a great question. So by the way we're doing it now, no freaking way. We try to be reductionist, right? Let's figure out the one gene for ADD or for autism, et cetera, and realize that we are a complex emergent system. Looking at one dimensionality, which is DNA, which is your ingredient list, is not going to tell you what's happening with these complex diseases. So we have to take a step back and look at that system. We have to take a step back with these newer technologies and look at the dimensionality. Take cancer as an analogous example. They say, well, molecular targeted therapy is going to be the future for cancer. And again, I'm a cancer doc, and that's gobbledygook. Unfortunately, the average cancer on diagnosis has several thousand mutations. You can't model it, you can't target all of them. And so this notion of this reductionism to one element is probably wrong. We have to start to think about it, again, more like a physicist and engineer as this complex system, and then I think we can make real progress.
Okay, I'm Daniel Foltin from Israel. I'm dealing with health economics. I would like to ask all your beautiful presentations how the world can support all this while we are hearing all the economical crisis, all the what called the old economy, the E7 countries are weakened, all the economy is going to the, the G7, all the economic are becoming weaker. The economy is going to the other side. Maybe China will be the leader. And how does it goes with not enough regulation in those countries, specific to what Raman told, and before Giora, if we wish that more governmental aid will be in. Thank you.
I think it's a great question. Certainly in the U.S., the economy and the GDP, percent of GDP that healthcare consumes is untenable. It's largely untenable because we're still enamored of savior approaches. You know, you're really sick and I could rescue you, versus fundamental, very boring, very simple beginnings to improve the area of population health. And we are starting to see that cost curve bending, actually, as people begin to make better choices. We are certainly looking at experiments that link healthcare with social strategies, much more than thinking about healthcare as an isolated, sort of great therapeutic solution for the world. So much of the conversations around this, in our case, involves combining social agencies with healthcare agencies to address some of those modifiable factors that I think people have referred to. So for example, I think we know that that for asthma in children, which is the commonest chronic illness, that we find many of our children come back to the hospital not because they don't know they have asthma, but because they live in families where they may be living at the weekend in someone else's house and they don't have their medication, or they actually don't get the medicine, they don't pick up their medicine in time. We're able to look at those kinds of therapies and go farther upstream to solve those problems. So I think we're seeing a lot of emerging models, you know, in that arena. Certainly seeing that in a lot of the North European countries whose outcomes are considerably better at much lower cost. And the classic example I'll give you is in Sweden, where they have a kind of a persona called Esther. And Esther is an 80-year-old woman. She lives by herself. Her daughter lives, you know, 2 cities away. When they discovered all of the hospitalizations for hip fractures in this county in Sweden, which has the lowest cost and the best outcome, they discovered 2 primary reasons for hip fractures. One was that the light bulb was fused and the people were standing on the ladder to fix the light bulb, or the light bulb was fused and they decided they couldn't stand on a ladder and so they were going to walk down the stairs. So in this county in Sweden, they change the light bulbs on a regular basis. They've got a young somebody that goes and does that for not a lot of money, and they've nearly eliminated fractures. So I think while we simultaneously pursue these great, important opportunities of science and new discovery, we must get back to the conditions and issues of preventable illness that are largely addressed not through healthcare, but through a broader commitment.
So actually, I'd like to, I guess, raise a question on this. And a very large percent of healthcare costs are often consumed in the last year of a person's life. It's enormous, because there seems to be such a huge focus on the quantity of time, and we alluded to the fact that, yeah, people are living longer today, but it seems to me also that the quality of a person's life is an extremely important factor. And you know, is there a relationship, I guess, between this focus that we have on extending life and the cost of healthcare versus the quality of life, and you know, how that might affect ultimately how much we spend? There's a question.
I mean, look at it this way, is that there's this magic number of 83. Once you pass 83 years old, we don't put you in an intensive care unit. We don't go to heroic measures. We actually let you die with dignity. Remember, 1953 was the last year in the United States you could die with old age on a death certificate. So if we prevent disease and make people live into the 80s or 90s, the paradox is healthcare costs will come down dramatically.
Hi, thank you so much. My name is Aviva. I have a background in Western medicine, alternative medicine. I currently work for a biotech, biopharma company. I just really want to say thank you to all of you. It's so comforting seeing brilliant people on the inside looking to make changes, because there are so many of us that don't know that that's happening and have that fear. This is pulling from everyone's presentation, but Dr. Kodagal specifically, on seeing what you see within the hospital system. Those of us, I don't want to say at the Mercy, because I do think that there's a big push now in alternative medicine as a result of seeing that medicine is not reaching the needs of especially the people with chronic diseases. And there's a bit of intuitive medicine that's really coming out of this. How do you recommend that those of us who need to go into the hospital put our trust there? Really, like I had a family member go in recently with a stroke, and the only thing that kept me quiet was knowing that God is the chief medical officer of that hospital, and speaking to everyone from that perspective. Otherwise, I would be in a complete panic. And I know personally, I only go to my doctor when I know the exact drug that I want him to recommend to me, and everything else I take care of myself and do a better job. And he's a brilliant man, and he's a wonderful man. I have his personal cell phone number and call him in the middle of the night sometimes. But I don't really know what to do with that, or how to raise my child with that, or what to do in my community with that. And I would really love to hear what you have to say.
I don't want to be the depressing person in the room, because I feel pretty optimistic most of the time. But I would say that I would not trust your hospital, and that's a fundamental principle that you should follow. Not because that physicians are bad or nurses are bad, but our systems are perfectly designed to get the results that we get. And unless we fundamentally change our systems, it will be that way. One area that we've been exploring where I think there is knowledge around how to do this is really the nuclear industry, the aircraft carriers, and so on, where application of reliability engineering and reliability science makes a difference. These are called high reliability organizations, and they have been extensively studied, and they have some fundamental concepts that define how they work. And the most important part of it is, I think somebody referred to earlier, is these are complex adaptive systems, so they should be recognized as such. But using the high reliability engineering science, we have been able to make pretty dramatic impact on modifying human systems to make them more significant and more reliable. And a lot of that really depends upon prediction as a criteria. We do find that we are able to predict, if we apply the right theories, where somebody might get harmed, and we are able to mitigate it, and there's a whole science emerging around that. Healthcare, like firefighting, though, is a very unforgiving environment in which experimentation is difficult. And so under those circumstances, how do you experiment to create a safer system? And there's an emerging literature on that is quite interesting and promising. In the meantime, I would recommend you have somebody sit by your bedside if you are at a hospital. I would recommend that somebody check the medications, and I would recommend that you follow fundamental safety principles that you would follow in your home.
Shaishan Orr, I'm a faculty member at Technion, and I'm a systems biologist working essentially on the immune system and the complexity of it. And I guess the questions to the panel, on one hand, I fully agree that the humans are complex, and yet the systems in which we design our drug pipelines these days require large numbers. So if everything's personal, how can we, in the end, have the entire pipeline system be, averaging numbers, or in fact, how would this be cost effective? Would even the current regulation system of the FDA be relevant if the treatment is personalized?
Yeah. I can take a stab at it and to say that that's a very common concern about fragmentation of healthcare to the individual. I think that's taking it to a great extreme. But the reality is that in all major diseases that we suffer, 95% of the GDP spent on the chronic human diseases, there is a clear need to define the disease not on the clinical manifestation, like, for example, somebody comes into the hospital and is wheezing, he's called asthma. But the disease on a molecular level, it's not about wheezing. It's about certain biochemical changes. And it's very clear that there are patients who wheeze because mechanism A and patients who wheeze on mechanism B. And if you treat one that has mechanism A for a drug that works on mechanism B, all that you do for the patient is adding side effects for no or limited benefit. So the economics of putting compounds into people that have no benefit needs to be factored in, and segregating 19th or 18th century terminology of what a disease is based on phenotype rather than based on the mechanism, okay, is going to change. It doesn't matter how objection or what concern will be raised. The economic will come in once you prove that you can have, let's say, a quarter of the patient called asthma being treated so effectively and without no side effect. Those patients will demand that medicine. The physician would treat only with that kind of medicine. So today the treatment with asthma is for all comers and only few benefit, and many get side effects, including cardiac arrhythmias. In the way asthma is now being progressed, and certainly in the next 10, 20 years, there will be a called, my asthma is this kind of an asthma, and for that I will need that disease. And it will work very well for me, and I will be very safe. So I think it's premature to benchmark the economics of that situation, but the demand by patients and doctors will dictate it anyway, and the industry can kick and scream about it for concern of we cannot do medicine for everybody. That's not going to happen.
Yeah, I'd like to add to that. Many years ago, I used to go to the pediatrician expert with a sick child, and he would write something and say, okay, give this to him 3 times a day. And I would say, could you please let me know what it is? And he would say, it's a good medication, it's imported. So I would say, could you please let me know which medication it is? And only then he would raise his eyes from his papers and say, oh, it's you again. I think that that situation has changed. Today's patients know a lot more. They can Google, they can look into the literature, everything is accessible, and they come to the doctor and say, I've read this article recently, and I think that I need this. And the doctors listen. So there is a major change here as well. And talking about numbers, I have a friend in University of Chicago who says, you don't start a genetic experiment until you gathered 10,000 volunteers. So that's not for a small country, I'm afraid.